Welcome to the 2016 Protocol Update video. My name is Dr. White and I'm the Regional Operational Medical Director. As you know, pre-hospital EMS care is constantly evolving, and the Rappahannock EMS Council strives to keep providers in the region utilizing the best evidence-based protocols. While individual protocols may change, it is important to periodically review and overhaul the entire patient care protocols our providers are operating under. In addition, some protocol names have changed per the Virginia Office of EMS. I'm going to review some of the key changes that have been made. Please be aware that the new medications will not be supplied by the hospital pharmacies until the official rollout date of the protocols. I would like to begin with spinal immobilization. As I am sure you are aware, there have been many studies that have shown that traditional spinal immobilization, where a patient is strapped to a long board, can be detrimental to the patient. In addition, there's not a lot of evidence that the traditional long board presents a benefit to patients. Because of this, we thought it was important to review the spinal immobilization protocol. The protocol now contains a spinal motion restriction procedure. Spinal motion restriction consists of placing the patient in a C-collar and having them lie supine on a padded stretcher. This option still restricts the cervical spine from moving while allowing the rest of the spinal column to remain in its anatomical shape. This protocol will be discussed more in depth later in the video. We have also put into place a restraint protocol. Combative patients who cannot be calmed present a significant threat of injury to both themselves and others. Because of this, we felt it was important to have a more effective way of dealing with this group of patients. There is now a physical and chemical restraint protocol for providers to utilize. Effort must be made to perform patient assessment and document any injuries before application. It is imperative that the patient be assessed often and monitored after restraints are applied, to include monitoring of PMS in the restrained extremities. Patients may not be restrained in a manner that restricts respirations. Ketamine has been added to either augment or be used in place of physical restraints. Ketamine is an amnestic dissociative. It is considered an anesthetic and is dose dependent, but when needed in the appropriate patient, it has been found to be relatively safe with few side effects. It can work within 30 seconds of administration, making it ideal for rapidly and safely sedating patients. Of course, the goal is to calm the patient without application of either physical or chemical restraints, and this should be considered as a last resort. A stat kit is now being provided to allow providers, specifically BLS providers, to more rapidly administer the most commonly used emergency medications. The kit contains some medications that are well known to BLS providers and a couple that are not so well known. Nitroglycerin and aspirin have been provided for chest pain that is presumed to be cardiac in nature. Albuterol and Atrivin are provided for patients experiencing respiratory distress with wheezing. New to the region's BLS providers are Narcan and Zofran. Narcan is an opiate reversal and is to be nebulized into patients experiencing respiratory depression secondary to a suspected opiate overdose. Some common opiate medications are morphine, Dilaudid, and heroin. It is important for providers to be aware that these patients may experience vomiting and be very combative after receiving Narcan. Be prepared to help maintain their airway. Zofran is utilized in patients experiencing nausea and vomiting. For pain control, fentanyl is now going to be provided instead of morphine. Fentanyl is a more potent pain reliever, and patients often experience less nausea and less hypotension related to administration. TXA is the abbreviation for tranexamic acid. TXA is used to reduce bleeding in a patient who is experiencing hemorrhagic shock. The military has been using it since Vietnam with positive results. Time is important when utilizing this medication. TXA should be administered within 3 hours of when the bleeding has started. Caution should be utilized in patients that have a history of formation of clots such as DVTs or pulmonary embolisms. This medication is already used in some systems in our area. Before being able to utilize TXA, providers need extensive training and agency OMD approval. Our last topic is rapid sequence induction, or RSI. RSI is appropriate for patients who are not able to maintain their own airway but still have an intact gag reflex and cannot be easily managed by the provider. The induction agent has not changed from etomidate, which our ALS providers are already familiar with. Vecuronium and rocuronium have been chosen for paralytics. Both are considered good choices and based on their safety profile and emerging evidence in research. Only paramedics that are certified at the critical care level or designated as advanced practice may perform this skill. Agency level training needs to be conducted and providers need OMD approval before being able to perform this procedure. Quality assurance needs to be done on any call that RSI is performed and reported to the REMS Council. Please stay tuned for an in-depth review of all the protocol changes.
We will now discuss specific changes to each protocol section. The information in this presentation is to augment the study and understanding of the Rappahannock EMS Council 2016 protocols. It is still the individual provider's responsibility to learn the patient care protocols. Protocol names have been updated to the state VFib dataset. Some protocol names have changed. Certification levels were updated to reflect current levels. First responder has been changed to EMR, EMTB to EMT, EMTE to AEMT. Oxygen delivery has changed throughout to assure a SpO2 of 94 to 99%. This is so that you do not over-oxygenate your patients. In the administration section, Section 3.20, Treatment of Minors, 3.20.1 states that under Virginia law, a minor is defined as a person under the age of 14 years. Section 3.21 is sepsis pearls. This has been added for the management of suspected sepsis patients. In the medical protocols, under the cardiac arrest protocols, providers are to follow current 2015 ACLS guidelines. Each algorithm is listed separately, and flowcharts are included in the algorithms. There is a return of spontaneous circulation, or ROSC flowchart as well. There is now an indwelling medical device or equipment protocol. This has been added for ventricular assist devices. Be aware that there are many different types of ventricular assist devices. A website is listed for color-coded reference of the various devices. Pain control has been removed from the cardiac and trauma protocols to its own protocol. Morphine is no longer going to be provided. Fentanyl is to be utilized for pain control. There is now a behavioral patient restraint protocol. Patient restraint should only be used as a last resort. This protocol also includes procedure sedation for cardioversion. EMTs and above can use soft restraints to prevent patients from hurting themselves or other providers. It's important that you use law enforcement assistance whenever possible. Inform the patient you intend to restrain them. Perform a thorough physical examination and document the reason for restraint. You may not compromise circulation or respiration when restraining a patient. Restraints have to be able to be cut or released immediately in the event that the patient has a seizure or decompensates. There will be an example of patient restraint at the end of this video. For procedural sedation, intermediates and above may administer etomidate 0.3 milligrams per kilogram for brief sedation. For longer sedation, administer Versed 0.02 milligrams per kilogram. For chemical restraint, in lieu of or in addition to physical restraint, administer ketamine 2 milligrams per kilogram IM. You may repeat once after 10 minutes if necessary. If an IV is available, you may administer 1 milligram per kilogram of ketamine. If ketamine is ineffective, consider Versed 2 to 5 milligrams, IV, IM, IN, or IO. In the allergic reaction anaphylaxis protocol, emergency medical responders may administer an epinephrine autoinjector if the patient has one. Under the altered mental status, EMTs may now administer Narcan via nebulizer from the stat kit. Titrate for sufficient respiratory effort, and then the nebulizer may be discontinued. A demonstration of how to utilize a nebulizer with a bag valve mask is included at the end of this video. All levels from EMT through paramedic may use the nebulizer route of administering Narcan. Thiamine has been removed from this section as it's been removed from the formulary. In the chest pain protocols, EMTs who are approved to use the stat kit may administer 324 of aspirin if the patient has not already had some, and nitroglycerin for suspected cardiac chest pain. Nitro can be given every 5 minutes up to 3 times, provided that the patient does not become hypotensive. For pain, EMT intermediates and paramedics are now using fentanyl instead of morphine. There is no longer an altered levels of comfort protocol. Nausea vomiting is now its own protocol. It remains the same otherwise. In the overdose poisoning toxic ingestion protocol, Narcan may be utilized through the nebulizer. ALS providers are still able to administer Narcan 0.4 milligrams at a time, IV, IM, IO, or intranasal. In the seizure protocol, ALS providers will be giving Versed instead of Ativan to control seizures. Versed is 2 to 5 milligrams, intranasal, IV, or IM, that can be repeated once at 5 minutes. The pediatric dose is 0.1 milligrams per kilogram, up to a max single dose of 2 milligrams. In the trauma protocol section, a bleeding hemorrhage control protocol has been added. This protocol was added to address wound packing, hemostatic agent usage, tourniquet application, and tranexamic acid usage. A tourniquet is indicated early to control severe hemorrhage. Proper placement is imperative. Spinal motion restriction has been added as an alternative to spinal immobilization in some patients. It became a standing order from the operational medical director November 19th of last year. Each agency should have received a memo from the Rappahannock EMS Council outlining the steps to take to utilize this policy. Agency training must be performed in order for this procedure to be utilized. A demonstration of spinal motion restriction will be shown at the end of this video. Under the clinical procedures area of the protocols, the scope of practice table has been changed. End title CO2 was added for EMTs through critical care paramedics and advanced practice paramedics to use. The therapeutic hypothermia was removed as an American Heart Association recommendation. Airway has been separated into sedation-assisted and rapid sequence induction. Sedation-assisted is non-paralytic. Critical care paramedics and advanced practice paramedics may use ketamine for post-intubation sedation. Rapid sequence induction involves a paralytic. This is an added protocol for providers at the critical care paramedic and advanced paramedic level. You must be signed off by your agency OMD in order to perform this skill. Under the intravenous and intraosseous access area, EMT intermediates who have been trained to access PICs and signed off by their agency OMD may now access PIC lines. Paramedics who have been trained to access indwelling medication ports and signed off by their agency OMD may now access those as well. As previously stated, therapeutic hypothermia was removed due to the American Heart Association recommendations. In the reference section, we have added a hospital, trauma center, and burn center list. There is an adult sepsis signs and symptoms chart and the American Burn Association's burn center referral. The acute stroke patient transport consideration has been removed. The following need additional training and agency OMD approval before being utilized: rapid sequence induction, PIC, central line, and medport access, and the STAT kit for BLS providers. As of March 1st, TXA has been added to the formulary. May 1st of 2016, the narcotics kits are changing. Fentanyl, ketamine, and a paralytic are going to be added, and morphine's removed. In addition, etomidate is now going to be in your narcotics kit and not in the medication box. We will now demonstrate patient restraint, bag valve mask with nebulized Narcan, and spinal motion restriction.
Now we're faced with an all too common occurrence for those of us in EMS. We have a patient that's being violent or combative to us and is a danger to themselves, others, or the EMS crew itself. We should always have law enforcement on the scene with us and attempt to utilize them wherever possible in this process, because remember, EMS providers cannot use handcuffs. Only police can apply those. So what we're going to demonstrate now is our new patient restraint process. Okay. Again, it's important to note that this should be a last resort. The patient, again, has to be a danger to themselves or others for us to do this. We should always try to verbally de-escalate the patient and apply our psychological first aid to attempt to calm them before we consider any of the either physical or chemical restraint. If we're unable to verbally de-escalate them, then we're going to use a team-based approach. We should always try to utilize as many personnel as we have available to minimize the danger of this process to ourselves or to the patient. So it's critically important for those of us as the attendant in charge or the paramedic in charge of an ambulance to delegate team roles and talk through the entire process to our team before we go and attempt to perform this procedure on a patient, so we are all coordinated and we can perform this safely. Also, before we perform this delegation, we need to explain to the patient what we're going to be doing and why we're going to be restraining them. Again, we have to remember, just like any other patient, we have to be informing them so that we are keeping within all of our medical ethics. Okay, so I'm going to go ahead and delegate our team roles. Please take the patient's legs above and below the joint, patient's right arm, and patient's left arm. You'll notice that our patient is fighting us a little bit with this procedure. We have the patient's dominant arm that is up and above their head. That's going to help us control the patient's torso and keep them from using their chest muscles, their abdominal muscles, from defeating our restraints as easily as they might otherwise do. You'll also notice at no point during this process do we have anything going across the patient's chest or their stomach. We're not going to be laying on top of the patient or performing anything that's going to keep their chest wall from expanding, because we want to minimize that chance of the patient positionally asphyxiating or having any type of breathing difficulty complications as part of this skill. We also will have performed a full head-to-toe patient assessment to make sure that the patient does not have any injuries that might be reversible or any disease processes that are causing them to act out in this manner. Again, this procedure should always be a procedure of last resort. So we have the patient restricted in movement right now with our team members, and we are going to be, for the purposes of this training, using cravats. You can either use cravats or some other type of commercial soft restraint. We recommend that you do purchase commercial soft restraints for your personnel if there is a chance of you using this procedure very often, because that is going to maximize the safety for both you and your patient. But no matter what you elect to use, you must make sure that it's something that has a quick release knot that you're using to tie it in the case of cravats, or has some type of quick release clip with a commercial tourniquet. Again, if your patient starts to deteriorate in any way and you have to have access to them quickly, we have to be able to cut or unclip or untie these restraints quickly to be able to get access to that patient. So we're going to go ahead, because we're using cravats in this patient encounter, we're going to have our cravats rolled such that they're a minimum of a width, an inch in width apart. That's going to keep from making too deep of a ligature into the patient's extremity. Again, we're going to try to make sure we don't do any unnecessary damage to the patient by this procedure. We're going to go ahead and tie off the patient's extremity, again with a quick release knot. Just tight enough to, again, to ensure that we've captured the patient's movement so as to preserve their safety. And then we're going to tie the other end of the restraint off to a non-movable part of our stretcher. We recommend the stretcher frame. Once we have the patient secured, we're going to perform in a stepwise manner, restraining our patient one by one limb at a time. So I'm going to come down and assist my partner as he applies the next restraint. And while we're applying these restraints as well, it's very important that we continue to talk to our patient, to try to de-escalate the patient, explain what's going on, why we're doing it. Okay. Once we have all 4-point restraints applied, we're going to go ahead and we're going to do reassessments for pulse, movement, and sensation in every limb at a minimum once every 15 minutes. But we also highly recommend that you do once every 5-minute PMS assessments. If you find that circulation becomes compromised in any one of the limbs, attempt to readjust your restraints or find another alternative so as to not compromise the circulation in the patient's limbs. And then if you have an ALS provider that is assisting with part of this procedure or intercepts with you on a BLS truck while you're en route to the hospital, it's also critically important that if you cannot verbally de-escalate the patient, to consider doing a chemical restraint on the patient as well. We don't want them fighting these restraints too hard and causing ligatures in their extremities, so that chemical restraint process will calm them down and prevent them from causing further damage to themselves. Thank you.
We have an adult patient suffering from an opiate overdose with respiratory depression and an altered mental status. Please ventilate the patient with oxygen once every 6 to 8 seconds. We're going to prepare to nebulize Narcan. The Narcan will be attached to oxygen at 6 to 8 liters per minute. Once attached, continue to ventilate the patient once every 6 to 8 seconds. Our next scenario is an adult female patient who is the driver in a rollover MVA. The patient does not have any loss of consciousness and has a GCS greater than 14. Crews on scene have assessed the past medical history and are beginning their physical assessment. Upon palpation of the neck and back, they find generalized spinal tenderness. A tech has taken and maintained manual C-spine mobilization, while the assistant has sized an appropriate C-collar. Upon placing the C-collar, the patient will be directed to stand and transfer herself to the padded cot. Crews will continue their assessment of the patient and perform a secondary physical exam. Our next patient is an adult female who has fallen from a ladder. Upon arrival, the crews find the patient ambulatory, complaining of right arm pain. She is able to answer questions appropriately and has a GCS greater than 14. Crews find no special circumstances or distracting injuries. The patient will be transported in a position of comfort on the cot. The arm will be secured with a sling and swath. Crews arrive on scene of adult female trauma patient who has suffered a fall and is now unconscious. Due to the patient's altered level of consciousness, they will take manual C-spine mobilization and apply a cervical collar. They will continue immobilization using a long spine board and spider straps.
One, two, three.
And we're gonna roll back. 1, 2, 3.
This concludes the Rappahannock EMS Council 2016 protocol video.